Hello there, and thank you very much for opening up this video. I really do appreciate it. For those of you who don't know me, my name is Bond, James Bond. I'm a health and fitness expert based in the United Kingdom. Now, how to put this? We're in the middle of election season in the United Kingdom, and on the 12th of December 2019, the people of Britain will be electing a new government. Now, in the last few days, there's been considerable media coverage about the NHS waiting times. For those of you who live outside the United Kingdom, you may not be aware that healthcare in the UK is provided free of charge, paid for out of taxes. Now, there's been a lot of talk in the press about high waiting lists. Back in 2001, I wrote about this and no one listened to me. It's a classical case of I told you so. Like the Rotherham child abuse scandal, the A-level mix-up crisis, the student debt crisis, and my prediction in 2008 that poverty was the #1 cause of obesity, I've been proven to be correct about NHS waiting times. Okay, and all 9 of my things that I wrote about in 2001 have been proven to be correct. All except one are within the remit of NHS management, and there is no conflict whatsoever between NHS management and clinicians for one simple reason. Well organised, good quality clinical medicine is value for money medicine. I'm going to go through my 9 reasons in a minute, but let me just give you just one example. Let's take asthma, a very common condition. My father is a general practitioner before he retired. And what happened was, if someone was diagnosed with asthma, he'd say to the patient, okay, very sorry that you've been diagnosed with asthma, but it's not the end of the world. Now, I encouraged the patient to join the British Asthma Society, go to regular lectures on asthma, read journals, and he said, within 6 months, I want you to know more about asthma than I do. And when you come for your reviews, I want you to update me on the latest advances in asthma. And this is how the typical patient will be told to keep a peak flow diary, get their asthma under control. But this is the typical review, which was done every 4 to 6 months. Hello, Mr. Patient, how are you? Patient would say, very well, doctor, how are you? Fine. Has there been any change to your asthma? None whatsoever. How often are you taking your blue inhaler? I'm not. Great. Okay. Can I look at your peak flow diary? Yep, all in order. Okay. Can I examine you? Yep, quick examination. Has there been any change? Yes. Any ill effects? No. What are the latest advances in asthma treatment? Tell them. Okay, very nice. Shake hands. See you in 6 months. Okay. Compare that to a patient going gasping for air, shortness of breath, cough and wheeze, need asthma out of control, being admitted to hospital, serial peak flow, serial pulse oximetry, serial arterial blood gases, intravenous steroid, okay, being nebulized, put on oxygen, and in worst case scenario, taken up to intensive care. What costs more? What my dad did cost a hell of a lot less. Well organised, good quality clinical medicine is always value for money medicine. In every single case, without exception, irrespective of the disease, the best clinical outcome is always the cheapest. Always. Okay? So let's talk about the 9 things that I predicted about in 2001, but no one ever listened to me. Okay. Number 1. Okay. NHS management cannot do anything about this, but there's a problem with migration. It's been written in the Lancet that in the last 10 years, some 5 million people have registered with GPs. We haven't increased the number of GPs and doctors to cope with that. So there was no wonder this was going to happen. What actually happens is, in 2001, the then President of the General Medical Council, Professor Graham Cato, said in a speech to GLAD, Gay and Lesbian Association of Doctors and Dentists, that there was a huge expansion of doctors and dentists, but that would still be 50% short, so we need to import. How is it the world's 5th richest country needs to import doctors? That just doesn't make sense to me. Well, I can understand what they're doing. It is cheaper to send our students abroad, basically, to learn medicine in another country and bring them back here than it is for us to produce them ourselves. It's stupid. What should actually happen, it's again, I wrote about this in 2001, it will be cheaper in the long run that once the student hits their clinical training in years 3, 4 and 5 of the medical course, they should be given a salary of, let's say, £200 a week, and basically be seen as future employees of the National Health Service. That would make far better sense, but unfortunately it's too sensible, and their fees should be paid for by the National Health Service. That's what makes far too sensible. Okay, that's the first thing. Now, how to put this? Let me go through a few things. Now, some basic principles you need to know about. In my day, if you were on call, you had to do either Monday to Friday, 8:30 a.m. to 8:30 p.m, or Saturday and Sunday on call, 8:30 a.m. to 8:30 p.m, or you'll do a week of nights, Saturday to Friday, 8 p.m. to 9 a.m. And trust me, at the end of those 91 hours, you will be very tired. Now, on a typical shift, your 12-hour shift, you'll get about 15 patients coming in. Okay. Now, how to put this? If those patients came in, you'll need to write up your clerking. Okay, that's about 6 sheets of paper. Fill in a drug prescription form, x-ray form, ECG request form, blood forms, and an interim discharge form. Okay, and in each sheet of paper and those forms, you would have to put the patient's full name, date of birth, and hospital number. Now, that can take about 6 minutes per patient. Now, every so often, if you're lucky, the patient's notes arrive that they've been previously admitted, and so in the back of the notes there are the addressograph labels: name, address, date of birth, hospital number. So those 6 minutes is cuts down to 1 minute. Now think about it: 15 patients come in over a 12-hour shift. 5 minutes saved per patient. 15 times 5 is 75. That's enough time to see 3 patients. Now, how is it NHS management can't think of sorting that out? I mean, that just is absolutely balmy. I just don't get it. Okay, they're paid a lot of money. How is that possible? Okay, and it only costs about £35 for one of these labels printers, so I just don't foresee the problem. And the labels, as a must, are cheap. Okay, get them on eBay. Next one, a great GP, admittedly, very biased example. My dad. Okay. If he told me that if you had a patient who needed social assessment, who you think wouldn't cope at home, start social assessment from the first day they're in hospital. He actually taught me that, said, once you've clerked the patient in and you hand those notes over to the patient, you write to the nurse, you write in the note, patient needs social assessment, and tell the nurse, can you please start social assessment today and put it in the care plan. If you do that, you can save the patient 3 things. 1, repeated hospital admissions. 2, social at least a month in the hospital. And secondly, you can save the NHS about £300 a day in a needless stay. Now, what actually happens is, if the patient can't cope at home, what happens is they go home, they can't cope, they're back in a couple of days, while social care is sorted out. Social care needs to start off from the first day. And what actually happens is, none of my patients who I did that to ever ended up as bed blockers. Okay, because I always start social assessment on the first day. But that's a different story altogether. Who's going to listen to a junior doctor? Okay, now what actually happens is, on call, the consultant on call should do a review of each patient. It's called a post-take ward round. Now, I had one very good consultant, a locum, who at 6:30 at night would grab the daytime house officer and just say, get the middle grade doctors to cover you, and said, I need to do a post-take ward round, please present the cases. Great, fantastic. So what then happened is, he'd go through each case, okay, for 3 reasons. 1, he'd give that junior doctor constructive feedback on each case. Okay, it was good teaching practice. Number 2, it will help avoid patients going into arrest. Number 3, just as importantly, how to put this, it would make the morning ward round a damn sight faster. What he'd done, and round about, once he'd completed the ward round, he was very good. He said, look, you're tired, you've had a long day, go home. And that was really good of him. I respect him for that. So what then happened is, the nighttime house officer would take over, and at 7 o'clock the following morning, he'd basically say the same thing again. He'd say, it started the ward round at 7 o'clock. First 10 patients, dead easy. No change. Done that really quickly. And then he'd give constructive feedback on the remaining ones. And again, what would happen is, the post-take ward round would be over by 8:15 at the very latest. Now, by law in those days, the the middle grade doctors at 10 o'clock had to be released for their day jobs. But he'd finish at 8:15, so it didn't affect the working day. Why NHS management have not thought of this is beyond me. It just beggars belief. Now, in 1998, I wrote a article for BMA News Review, and how to put this, in those days, NHS waiting lists for outpatient appointments were inflated by 10 to 30% due to non-attenders. So in those days, I wrote an article, and this is well before the days of mobile phones, on 5 steps to cut down NHS non-attenders. Number 1, a reminder letter sent 1 month before the appointment. 2, send them a telephone call. Can you come? Thirdly, a list of people who can come at the last minute if there's any last minute cancellations. Fourthly, discharge the patient if they don't attend. And lastly, a fine, a financial penalty. If you don't want to attend, if you don't attend, basically you've got to pay for another one. Okay. Nowadays with text messaging, they could very easily do a text message. Okay. Really, really easy to do. Okay. But why have they done it? I don't know. Now, in my run up to my conjoint finals, I actually had I trained with 2 great surgeons, and one of them was a urologist, men's waterworks, and what he had this great practice. What he'd do, he'd see the patient in clinic, and then he'd list them for surgery. Okay, and then he said, I don't need to see you between now and the operation. Okay, freeing up appointments. So many consults say see in 6 weeks, see in 6 weeks, see in 6 weeks. Not necessary. So what then happened was he'd free up appointments. Now, once you've had the operation, if appropriate, he'd say, I don't need to see you again. I'll give you an open appointment to come back if need be, but nice seeing you, and blah blah blah. So that would free up a lot of appointments, but it's not commonly done. That's a really good practice. Now, my dad's practice in those days, the GP would send a referral letter. He'd do the baseline investigations and then write on the form, this patient's been referred to Dr. X, please send them to Dr. X's clinic. They don't do that anymore. So what happens is the GP had to do these investigations, send the patient to hospital, get them done, get the results sent back, clip them to the referral letter, send them back. That just wastes time. Because what happens, but GPs don't have the time to do that anymore. So what happens is the patient's sent to hospital, seen by the consultant. The consultant then does the investigation, says see you in a month and come back. What a waste of appointments. Okay, stupid. Now, the last one, stupidity. This is really stupidity. And NHS management really need to do something about this. Let me give you one example. It all comes down to training of GPs. There's a very common condition that affects a lot of children called earwax. Okay, build-up of earwax in the ears usually is harmless. Now, what will happen is sometimes they have to be referred to the ear, nose, and throat surgeon, the otolaryngologist to be technical. And what the good GPs will do is just say to the patient's mother, because it's usually children, would you mind putting some olive oil in the child's ear and lie down for 10 minutes while they do that? Okay. That would soften the earwax. So by the time they went to see the specialist would look on the microscope and just pick it out because it's been nice and softened. If that didn't happen, what would happen is the child would see the consultant, said, okay, great. Put the olive oil in your ear, come back in 1 month. Again, wasting appointments. It comes down to the quality of GPs. Also, in terms of a GP admission to hospitals, there were when I was in practice, there were some GPs who were brilliant, and if they admitted someone to hospital, you have to take it very seriously because the GP had done everything he could, so it was really serious. Don't have a problem with those GPs, but there were some who would just admit willy-nilly, and they used to literally carry a government health warning. And I remember one, and the one that really gets my goat is needless blood transfusions. Now, I remember one case, this lady was admitted on her birthday, for a blood transfusion. So, and this lady's passed away, so I'm not breaching confidentiality. So this lady comes in, and I said, what's brought you in, my dear? And she says, I've got an abnormal blood test. I've got a letter from my doctor. Can I see it, please? Low hemoglobin, please transfuse. I thought, I said, why has he sent you in? I'm getting short of breath. When are you getting short of breath? After my daily walk. How long's your daily walk? 5 miles. I thought, how long does it take you to recover? I said, 5 minutes and a cup of tea. I said, my dear, there are people quarter of your age who can't do that. Okay. So, but against my advice, the patient was admitted and transfused, and had a very angry haematologist who was very angry about it. Needless to say, what then happened was, how to put this, there was no need for the transfusion, and what a waste of NHS money. Okay. Another case, this patient was on my ward, very nice gentleman, a chance finding. He'd learned to live with a low iron level in his blood. Okay. And what then happened was, my team just said, I think we need to transfuse him. I said, don't, he's learned to live with it. Okay. But against my advice, they transfused him. And a couple of weeks later, my consultant came up to me when I was doing nights. Said, how much contact did you have with this person? It was one of my patients. I said, why, what's happened? He said, he's HIV positive. I said, God. I said, I told you not to transfuse him. But I did. Went to see him a couple of weeks later when I came back from a week's leave, and I just said, really sorry to hear what's happened. And then says, yeah, I'm really sorry. No one listened to you. Then had to do some more blood tests on him, put the yellow stickers on each form, had to put the yellow stickers in each blood bottle, took him personally to the path lab, please process carefully. 10 minutes later, this stupid lab technician comes on my ward and says, this man is HIV positive and I am not risking my staff by doing this blood sample. You prick. If you said it any louder, I might have to tell them they could have heard you in Australia. I had to transfer this man to another hospital. So in a nutshell, good quality, well-organised, good quality clinical medicine is value for money medicine. So what happens is, 1, we need to address migration. 2, we need to get labels printed. Okay. 3, people who need social assessment need to start social assessment on day 1. Need a post-take ward round on half past 6 at night. A post-take ward round at 7 o'clock in the morning. Then my 5-point plan to get people in for NHS outspective audits. That urologist practice, follow my dad's practice, and stupidity. My name is Bond, James Bond, leaving you shaken but not stirred. Bye-bye. By the way, can you please subscribe to this YouTube channel and comment below. Speak to you soon. Bye-bye.